I would like to introduce Adam Hayden from Indianapolis and IUPUI. And he will be presenting a talk called Inside My Head, an Illness Narrative from a Brain Cancer Patient's Perspective. So thank you, Adam.
Thank you. So I'm going to present a case study to you. The subject of that case study is me. So this is my story. And here's what we're going to do. In the words of Dr. Sharon, we're going to establish a therapeutic partnership. So I'm going to offer my narrative to you in hopes that what you will do is to absorb and interpret my narrative and that you will be moved to action as a result. We're going to focus on three themes through this storytelling, through this narrative today. I want you to pick up on the following. So I want you to understand how important touch is in a physician and patient relationship. So you're going to have this theme of touch and human connection that's going to carry through the narrative that I offer to you today. I want you to understand medical epistemology, what people know when they're justified to claim that they know it, and how knowing those things may guide the delivery and quality of the medical care. And I want you to understand close listening. So I'm going to tell you a narrative, and I'm going to emphasize the things that I think are important, but you may notice nuances between the lines, and you may teach me something in the process. So I'm 35, I'm married. This is true that today is my 7th year wedding anniversary. So, right? It's great. My wife is right there, and she said, I mean, we're going to spend our wedding anniversary at a conference.
You have to confirm it's the 7th.
Yeah, that's right. That's right. Okay. We have 3 kids, 3 boys. Their ages are 5, 3, and 1 year old. So it's crazy around the house. There's something else you should know about me. That 1 year ago, just over a year ago, I was diagnosed with an aggressive and so far incurable form of brain cancer, a glioblastoma multiforme. So I'm going to start the narrative in an operating room. We're going to leave that operating room and then work our way back to it. There's a voice that comes just over my right shoulder, speaks my name, Adam. My eyes are darting around the operating room, I think very much like a first-year resident. Who's where are the instruments, what are the monitors displaying? A nurse notices that my eyes are darting around and she says, would you like to see the monitors? I say, yes, I would like to see the monitors, and she directs them sort of towards me. My head has 3 screws drilled into the skull, 3-point fixation. That's then in a Mayfield clamp that is bolted to an operating table. This is brain surgery, and I'm awake. So just to my left is a monitor displaying my functional MRI image that was taken just 2 days prior. I remember thinking that MRI scan looks like a weather map, like a meteorologist. You know, the areas of concern are sort of highlighted on the map. There's a big shadowy cloud. This is a 71 millimeter primary brain tumor that's in my medial-right parietal lobe. So that's like having a baseball right here. Directly in front of me is a monitor showing a video feed from an instrument-sized camera. That video feed, I see the hands of my surgeons, 2 of them, cauterizing and resecting tumor. Just here, monitor, I'm laid out on the bed. Just here is Megan, a nurse in the operating room. Her sole responsibility is to hold my hand through the procedure, to translate the doctor's orders to me, to feed me ice chips with a spoon. All the activity in the operating room, I think Megan has the most important job of all. I can still bring to mind, just in vivid reality, her hand, Megan's hand, but in that latex blue glove, you know? Because we want human contact, but not too much. and she's got to get that glove on. It's to protect her or to protect me, I'm not sure. But you don't just walk into the operating room. So we're going to rewind a little bit just to give you some markers in the story here. That's on May the 26th of a year ago. So we're going to rewind just a little bit to May the 13th. On May the 13th of 2016, we reached sort of a climax point of around 15 months of strange, episodic dizziness and weakness. You could even go so far as perhaps to call it peripheral neuropathy. So for about a year or more, I've been working with my general practitioner to sort of go through the checklist to figure out, what does Adam have? Or what does Adam not have? Is it positional vertigo? Maybe. I went to physical therapy. Turns out, no, it wasn't positional vertigo. Adam does a lot of computer work. Perhaps he's pinched a nerve and he has bad posture, and somehow that's affecting circulation and he's getting dizzy as a result of it. Oh geez, he's recently married, he has a stressful job, he's a project manager, kids at home. Maybe he's stressed out, and stress manifests itself in many different ways in the body, and maybe this is causing this episodic dizziness. Turns out, no, it wasn't that. So over this course of about 15 months, this episodic dizziness is increasing in intensity, in frequency, in duration. May the 13th was a Friday the 13th, 2 days before that. On Wednesday of that week, I was driving home from work, taking my usual route home, and I feel one of those episodes begin. It starts at the base of my skull, it goes upwards, and then takes a turn down the left side of my body. Usually that would go down my leg, it would end up at my foot, kind of a tingling sensation as though your foot had fallen asleep. This time was a little bit different. There was left arm involvement, left hand involvement. My left field of vision began to close in around me. I'm in, rush hour traffic, driving home. This is my regular route, so I know exactly where a gas station is and where I need to get to, and that I've got to change lanes to get there. So I know that right arm is fine and that left arm is messed up. So I reach across the steering wheel, hit that blinker. I'm coming over. Look out. So I pull into the gas station. I make 2 telephone calls. The first one to my wife, and I say, Whitney, this is the worst episode yet. I then call my doctor's office, and I say, hey, I need to get in as soon as you can see me. They could see me 2 days later. There's probably some commentary on the infrastructure of American healthcare buried in there that I'm not going to get into right now. So that Friday the 13th, that morning, I go to see my general practitioner. She is visibly surprised that I continue to have these symptoms. You see, we had been checking in after I had seen different specialists, and I was 34 then, in general good health. The joke that I tell all the time now is that other than my brain cancer, I'm actually a pretty healthy guy. As was true then. So certainly the feeling was, well, if you've got something really bad going on, you would be in much worse shape. I was just managing and enduring. As I worked, having these episodes, I knew to always have a chair in sight. Riding up the elevator to work, I would brace myself on that rail, have conversations with colleagues, all while sort of fighting through this dizziness. Friday the 13th, my general practitioner says, I'm gonna perform an examination. So after now, a bunch of study and a bunch of realizing what people like my situation go through, this is a very basic neuro examination that my general practitioner was providing. She's a family medicine doctor. So does not have specialty in neurology, neuroimaging, certainly not in neuro-oncology. So she's used to seeing snot-nosed little kids like mine who come in because their throats hurt. So she performs this neuro examination. She makes 2 fingers like that. Adam, grab my fingers and squeeze. She places her hands on my knee. I'm going to press down. You try to resist. I'm going to put my hands on either side of your head. We'll go one at a time. I'm going to bring my hand into view. You say yes when you see it. While this examination is being administered, right side is fine. Left side, unknown to me at the time, is just gone. Huge visual field cut on my left side. So my doctor knows something is very badly the matter. So now she has to do something. She can't just stop and say, hey, time out, I'm going to step out, I'll be back in a minute. She has to recall, what was that medical training that I did so long ago? She has to think about, how do I get Adam to an MRI very quickly and very urgently, but that I don't frighten him? So she's performing this neuro examination, she's formulating and rehearsing what her next steps will be, and all the while staying perfectly calm. The burden of professionalism, of communication that are placed on our medical professionals is great. And from a patient's perspective, means everything. So my doctor communicates to me that we have to have a stat MRI. I didn't know that stat was actually something people said, but it really is. It's not just Gray's Anatomy. It's really stat. So Adam, I'm ordering you to do a stat MRI. So her office helps to schedule that at the closest outpatient imaging facility. I call Whitney. Whitney's at work. Whitney is an occupational therapist at an inpatient hospital, a level 1 trauma hospital. So if it's happened to people, Whitney's seen it. I call her up and I say, hey, the doctor says I need an MRI and I need to do it now. And Whitney's like, oh, well, I'll come and I'll meet you there. And I said, oh, it's fine. You don't need to leave your work day. I didn't realize, I didn't understand, I couldn't comprehend the magnitude of a stat MRI from a general practitioner's office. Whitney did, and she met me there. So I change into scrubs. I get in the MRI bed. This is all a foreign experience to me. Midway through the scan, they pull me out of the tube, and they say, Mr. Hayden, we're going to place an IV. So they're placing an IV to deliver contrast dye. So typically when you get a scan, because now I've had about 14 MRIs, perfusion, for me, is just sort of part of the package. But for a lot of people, if you get an MRI, you're not placed with an IV. You're not given contrast dye right away. So another alarming signal that I had no idea was something to be alarmed about. I thought, okay, well, this is the time when they give you the IV. So what was rendering on those radiology text screens is a 71 millimeter mass in my parietal lobe. The techs are not in a position of authority to deliver that news to me. A doctor of radiology has to read the scans, has to prepare a radiology report. So they pull me out of the tube, walk me to the changing room. I put my street clothes back on. They walk me to the exit of the facility and say, Mr. Hayden, thanks so much. Your ordering physician will contact you when the results are available. So think about the burden that is placed on that radiology tech, who knows this dude has got a problem, but has to remain calm, confident, has to maintain the demeanor that I wouldn't think something was urgently the matter. We leave. Within 20 minutes of leaving the facility, my general practitioner calls my cell phone. Adam, you and your wife need to come back right away. We go back to the office. We open the doors, and it is like a Western film. You know when the bad guy kicks open the saloon doors, and some people are just struck, and other people take cover and flip tables. So I don't know all the intricacies of HIPAA privacy protection, but certainly that whole office of people knew something was up. Whitney and I walked in, and it was just, pin drop silence. All eyes were on us. I go to sign the little clipboard. I'm here. And the receptionist says, there's no need for you to sign in. The doctor's ready to see you. So change in protocol, right? I was like, okay, well, let's go on back. So my general practitioner sits us down, directs a monitor towards us. And she says, Adam and Whitney, I have very bad news. There's something that appeared on your MRI. She said, this is not my specialty. All I have is the radiology report. I just spent about 10 minutes on the phone with the doctor who prepared the radiology report, and I tried to ask the questions that I thought you would want to know about. She said, I'm going to read the report to you. So if you'd like to know about how to break bad news to a patient, reading a radiology report should not top your list. I've now become quite good at reading radiology reports, so That's good for me. If you need somebody to read one, just call me up. I'll do it for half the cost. So she reads the report to us. We stand up together. This family medicine doctor who thought surely nothing this bad is going on with somebody in such good health. A young father, young kids at home, here with his wife. We hug and we cry. My doctor and me and Whitney. So that's how the bad news was shared with me. The next week, I see a neurosurgeon. During that consultation, the neurosurgeon says, I cannot believe that the person that's sitting in my office right now is the same person that I was just looking at on those scans. So my tumor was placing pressure on motor sensory cortex. So this motor strip right in here. There wasn't tumor invasion in the area, there was pressure. The optic nerve bundle that goes from your eyeballs back to your occipital lobe, there was pressure, no invasion, but there was pressure. That was explaining the left visual field cut. So the doctor says, neurosurgeon, we're going to do a functional MRI. I'm going to go ahead and set up your surgery for Thursday of that week. And the conversation was, we could biopsy the thing, but no matter what it is, we're going to want to get it out. I have a very, very good friend who lives in California. We've been in Washington, D.C. together advocating on behalf of NIH funding. And she has a lower grade tumor than my malignant glioblastoma. She will remind you there is no such thing as a good brain tumor. So the surgeon said, man, that thing's coming out no matter what. So we had the functional MRI. Those scans were presented to the tumor board. I got a call from a strange number, and because I'm on the cusp of being a millennial, I didn't answer it, and I screened that call, and I just flipped my iPhone upside down. I checked my voicemail the next morning. The voicemail was from my neurosurgeon, who was informing me that we've decided to take my craniotomy from being under general anesthesia to an awake procedure to better map the functioning of my brain while they were resecting tumor. So I found out through a voicemail the day before surgery, Adam show up at the same time at 5 a.m. Why so early? Let me sleep in on brain surgery day. Show up, we're going to do an awake procedure. So I got a call that day before from the head OR nurse. Her name is Susan. The anesthesiologist. They walked me through the procedure. That was invaluable time. I don't know what everyone's reaction would be. I did all of my degree work here at IUPUI, undergrad and graduate degrees in philosophy. During my undergrad time, I actually studied with Professor Beckman for a period in medical humanities. So I just started to treat myself like my own case study. Going into the operating room, I said, this is going to be an intellectual curiosity. Because you're awake, you get to send messages out to your family. So my first message to Whitney was, this is every bit as interesting as I thought it would be. So Adam, here we are. We've resected a majority of your tumor. We have a choice to make. We can be more aggressive and resect more tumor at the risk of permanent left-sided paralysis. Or we can stop the procedure now, knowing that there is tumor remaining in the margins of your surgical cavity, but it's going to maintain the motor function that you have today. So Adam, what do you want us to do? The doctor reached down and placed his hand on my shoulder. That power of touch. That I couldn't move my head and I couldn't make eye contact, but there was a hand on my shoulder. I said, I don't want to be back here in a year regretting the decision that I made today. And the doctor said, you cannot make a decision based on what could happen in the future. You have to make a decision on where your quality of life is today. I'm a young dad. I like to play with my kids. I don't necessarily want to be paralyzed on half of my body if I can avoid it. So I said, that's it. Let's end the procedure. So that was over a year ago. By all the population statistics, 37% of people die within their first year. I'm now 13 months after that diagnosis. I just had an MRI scan last week. It's another stable scan. So here I am at this conference, able to give you the patient illness narrative from my perspective. And thank you.
Thank you, Adam. All right, questions or comments?
So thank you. Thank you.
Yes,
Thank you. That was a gift. And it's now our duty as listeners to fulfill the duties incurred by that gift. With your heart, you gave us that account with such wit and generosity and even self-deprecation, and we heard that. I have a question, which is, you were keeping track of the self-consciousnesses of others. And I have a question about the family medicine, your doctor. You did not say, it did not come to you to say, and why did the MRI wait 15 months? And it didn't in your presentation occur to her. And but that's all that was in my mind. I mean, this was a lot of symptoms you were having. What took them so long? But I didn't hear that in your account. And I wonder about that.
So thank you for your kind words in the beginning of that remark, and and I'll say, because I have the floor, it's an honor to give this narrative before you. So thank you for attending. So I think the graduate work that I did in philosophy was in the philosophy of science, and what we look at a lot in philosophy of science are models of inference. And because of the burdensome costs associated with the healthcare system. Things like differential diagnosis that you see on Dr. House isn't going to happen with every patient that walks into your office. I think when you see somebody in pretty good health and they're presenting with some strange symptoms, you make an inference. And I think most doctors are likely trained to infer when they hear the hooves to go to horses and not to zebras. And so I think I'm a zebra. The average age of diagnosis for glioblastoma is in the mid to late 50s. I don't have much of a family history of cancer or anything like that, not that there's a germline mutation for glioblastoma. But at any rate, I mean, I think, why should I order a $5,000 scan for this guy that seems healthy, just didn't fit with what she thought was the right thing to do? There is no, people have said, are you resentful or are you angry about that? And I don't find it to be productive to think about that. Yeah. It won't service me, to wonder what if we quote unquote caught it sooner. Mm-hmm. Certainly, if something came back to her where we felt like I'm angry about this, that's going to negatively impact the medical care that she delivers to future patients. Mm-hmm. Yeah. So I think it's part of my journey towards acceptance of this really devastating diagnosis has been to only worry about the things that I feel like I can affect or impact. Mm. Yeah.
Thank you. Sorry, was it me or?
Yes, please.
Well, one thing I was wondering about the narrativity that you could provide, which may not be affordable to many patients.
Yeah.
So there is something here about when we try to talk about patients' perspectives and narratives, we can't generalize and say all patients can produce narratives of the kind you produced. But apart from that, I was going back to your question at the beginning about giving attention to the touches during the process of the narrative. And the three that struck me, one was during the procedure when one of the nurses held your hand constantly, or it was almost like stopping you from doing something because you were awake or whatever else. The second one was during the bad news delivery, when you and your wife and the GP, I believe, the family practice, you hugged each other.
Yeah.
I think that touch is equally important. It's not just a touch between the physician and the patient, but it's also anyone in that environment where you have a touching way of communicating or experiencing.
Yeah.
And the third one, as you pointed out, holding you the hand on your shoulder. So already it shows that touch doesn't mean one thing.
Oh, good.
So it is so multiply meaningful. And how you might understand it, or how your family and the immediate contacts experience it, would be very different for many other people.
Sure.
But I remember one study that has been published on how physicians hate being touched. So they want to touch you to show empathy and rapport and what, even if in the wrong timing, but try to touch them in return and see what happens.
It works.
So thank you.
Thank you.
Thank you, Adam, for sharing your story. I'm also a cancer survivor, 5 years out, and so my question is more personal. Have you connected with other survivors, and how have you gotten from that experience being a survivor and hearing from other people? So of course, no cancer is the same, right? But how have you benefited at all from the network?
Yeah, tremendously. So tremendously. I think that so something that I've tried to. I've become very involved in the cancer community because glioblastoma is a very rare. So 3 per 100,000. So in a city the size of Indianapolis, there are 30 of us running around. And so much cognitive decline, language processing impairment, et cetera, makes it difficult to sort of have dialogue with other folks with my cancer. A very meaningful event for me, and Whitney attended also. We went to an advocacy event in Washington, D.C., and there were 300 and some survivors there of some form of brain cancer. And that is, there's something about, I was going to cuss and I don't. Careful. Cutting through the BS of, a lot of people don't know what it's like to have daily partial seizures, but I do. And these other brain cancer survivors do too. So you build relationships immediately in that context. So people that I met just over the course of 3 days in Washington, D.C., I now share daily email and text exchanges with. So people that I think are dismissive of virtual networks, Facebook groups, Twitter chats, that those feel like somehow you can't, draw like real meaningful connections out of that. I would disagree with them. It's been immensely powerful to me. On days that I'm too fatigued to get out of bed because it's been a chemo day or whatever, I'm able to sort of get out my iPhone and talk to people. So I am in contact, and I'm calling my senators about the healthcare stuff. That unless we have 3 hours.
Right. Good. And any others? Yes.
I can relate to your narrative. We took care of my wife's cousin's wife as caregivers. I'm an oncologist by training, but it was really different being on the other side. Mm-hmm. And one of the things that we realized was the importance of, during radiation therapy, seeing the same people go through it at the same time. Did you develop relationships and then keep up with them?
Yes. So I think there's in kind of a systematic way, you have 6-month follow-ups so that you're sort of back in that office again. So here's a cool thing. I was just recently connected. So I've been doing enough blogging and speaking on this experience that people in the Indianapolis area are beginning to know. I mean, I'm not a local cancer celebrity, but in groups, people know that I can be a resource. So I was recently connected with a newly diagnosed brain cancer patient and she's receiving radiation therapy at the same facility that I did. And so I was able to tell her, hey, when you go in, say hey to so-and-so. And she did. So I think that helped her to feel like she had an immediate connection at the facility, and helps those people know I wasn't just a sort of blip on the radar for 6 weeks, but in fact, I'm out here and I'm interested in what they're still doing, et cetera. So, yeah, some ongoing connection. Thanks.
I think the time is unfortunately up. If I might, I hope I'm not overstepping here a little bit, just cut me off if I am, but the eloquence and wit with which Adam delivered his talk comes through in his writing as well. He's an incredible writer, and he does have a blog. And you did say you blog, so I'm not fully...
offering stuff.
Yeah. So if you're interested, the writing is worth reading and thinking about for sure. You might pursue that a bit. But I don't have instructions, but I assume it's lunchtime at this point. So anyway, thank you to all of our speakers, and good questions.